The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies. But I could. Big Pharma, where you at? But, alas, I have no financial disclosures. Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Got the air conditioning working in the podcast studio again, and didn't cost an arm and a leg. Needed a capacitor. So that was pretty good news. Also, the podcast studio is my house, so that made it even more important and even better news to get that air conditioner fixed. I'm going to go over some guideline updates today. This will encompass the last couple years of ACC and AHA guideline updates. I'm finding that working in a smaller practice is making me feel more motivated to stay up to date with changes. I never worked as a nurse practitioner for a large organization, but I did as a nurse and as a paramedic before that. And obviously, it's always important to stay up on your own individual continuing education, no matter what your role is or no matter who you work for. But when you work for a large organization, you do have the organizational policies and procedures to fall back on. Ostensibly, there is someone whose job it is to keep the organization up to date on what everyone ought to be doing. So that always felt like a bit of a security blanket. But in my situation now, pretty much if I don't keep up and remain aware of new things and change my practice, it ain't going to get changed. So that makes me very motivated to keep learning, keep growing, keep stretching, and just keep up, because I definitely don't want to be the person who's stuck in doing things the way they were 20 years ago when I was trained or whatever. Also, before we get started, I'll throw out a plug for Open Evidence, the AI-based medical reference program that apparently almost everyone in medicine is using now. So I'm probably not telling you anything new, but it is pretty fantastic. I've been using it as my daily medical reference for, I guess, a few months now. I think I did a podcast episode or mentioned it on the podcast around the time I switched over from Hippocrates, but I've been pretty impressed with it. There's been one instance of it giving me a piece of information that I knew was outdated, but other than that, I've not picked up on any errors. It's more or less reliable all the time. There are some times when it's so busy that it can't answer your question, and it will say, oh, we're experiencing a very high volume of queries right now, and we don't have time for you. But that rarely happens. It is free if you put in your NPI number. I don't know what it costs to use if you don't do that or if you don't have an NPI number, but it definitely helps me day to day, and it helps a lot doing the preparation for these podcast episodes, because instead of running around and trying to find many different sources to pull from and compiling all of the things that I want to talk about or refresh myself on, I just ask it a question and it spits it all out. And I can even share that information with you. You will always find links in the show notes to whatever reference I used for that episode. And lately it's been Open Evidence. So I have no reason not to recommend it. And this is not a paid advertisement, of course, but it could be. Open Evidence, AI people, get at me. But no, I'm just sharing helpful information with you, my listeners, because that's the kind of sucker I am. Okay, here we go. Summary of recent AHA and ACC guideline updates. This covers 2024 to 2026. First up, we have acute coronary syndromes. We have antiplatelet therapy, specifically the default duration of dual antiplatelet therapy after PCI. The recommendation is aspirin plus a P2Y12 inhibitor for at least 12 months in patients not at high risk for bleeding, and prasugrel or ticagrelor are the preferred agents over clopidogrel. If there is concern for bleeding risk, you can drop the aspirin and just do ticagrelor as monotherapy beginning at least a month after the intervention. You can also switch from ticagrelor or prasugrel to clopidogrel after a month if you need to de-escalate a little. And if your patient is on anticoagulation, you still do the dual antiplatelet therapy, but you want to stop that aspirin somewhere between 1 and 4 weeks after the intervention, and then continue preferably the clopidogrel along with the anticoagulant moving forward. There's a change to the recommended strategy for revascularization. They're now recommending complete revascularization for both STEMIs and acute coronary syndrome without ST elevation. they're making a stronger recommendation to go ahead and do interventions on significant lesions that are not the culprit in that particular instance. They're recommending radial access for the interventions over femoral, and they're recommending intracoronary imaging, meaning intravascular ultrasound or optical coherence tomography, OCT. For cardiogenic shock, they are including the microaxial flow pump, also known as Impella, as a reasonable intervention in selected STEMI patients with severe cardiogenic shock, although there is a known increased risk of bleeding and limb ischemia with that. And in those situations, routine use of balloon pumps and ECMO are not recommended. For lipid-lowering therapy in the setting of acute coronary syndrome, high-intensity statin is recommended for all acute coronary syndrome patients, and they've added the option to initiate ezetimibe concurrently if a person with ACS is already on a statin at the maximally tolerated dose and their LDL is greater than 70. There's now a class 1 recommendation to add a non-statin agent, which would include ezetimibe, bempedoic acid, a PCSK9 inhibitor, or inclisiran. I'm developing a little pet peeve about fasting labs. I don't think we really have to make people come in fasting anymore. This was something that showed up at the recent PrimeEd conference that I went to when the cardiologist who was speaking on guideline updates mentioned this about fasting lipid panels. In the 2026 dyslipidemia guideline, it is reaffirmed that a non-fasting lipid profile is acceptable for most patients, carries a class 1 recommendation equivalent to a fasting sample for baseline lipid assessment, ASCVD risk estimation, and guiding lipid-lowering therapy initiation. There is minimal difference between fasting and non-fasting LDL levels in individuals with normal triglycerides, and multiple studies demonstrate similar prognostic value of fasting and non-fasting LDL and non-HDL cholesterol for predicting long-term cardiovascular events. The guideline explicitly notes that fasting is often impractical, requiring specific timing and frequently necessitating a return visit. And it doesn't say this, frequently necessitating listening to your patients complaining about not eating before they come in. I think this is a thing that we still do for no reason because that's just the way we've always done it. That has definitely been my experience in my own practice. I'm trying to get this out of what we do, and nobody will listen to me. Everybody looks at me like I'm an idiot and goes, but you have to come fasting for labs. That's everybody I work with and all of the patients. It's just ingrained in what we do. And I get that people are worried about the fasting glucose level. So my thing is, if it's a concern, then you have them come back fasting next time to get their fasting glucose level. Or you check an A1C next time. Because if it's over 100, you can call them pre-diabetic anyway and get an A1C paid for. Plus, people are not normally fasting. So if their numbers are that much higher when they're not fasting, don't we want to know that since that's the state they are in every day except 2 days per year when we make them fast for their 6-month visit? The guidelines do specify that you should get a fasting lipid profile in patients who have non-fasting triglycerides greater than 400, a family history of premature ASCVD or genetic dyslipidemia, and a known or suspected disorder in triglyceride metabolism. Blood pressure. The goal of blood pressure treatment in all adults with hypertension is less than 130/80, with encouragement to achieve a systolic blood pressure less than 120 when feasible. That's not a change in the numbers, but a change in the strength of the language that was used in the 2017 guideline. They're now recommending using the PREVENT equation to estimate CVD risk, which replaces the older pooled cohort equations. Key thresholds here: all adults with hypertension should go on medication when their systolic blood pressure is 140 or greater, or their diastolic blood pressure is 90 or greater. If they have clinical evidence of cardiovascular disease, diabetes, CKD, or if their calculated 10-year CVD risk using the PREVENT equation is 7.5% or more, then the recommendation is to start blood pressure medication if their systolic pressure is at least 130 or their diastolic pressure is at least 80. If you have a lower risk person who is in stage 1 hypertension, it's okay to recommend 3 to 6 months of lifestyle modification before we start medication. Then if their blood pressure is higher than 130/80, we should start medication at that point. As a reminder, they define stage 1 hypertension as systolic of 130 to 139 or diastolic of 80 to 89, and stage 2 is 140/90 or greater. And of course, with higher blood pressure, if we are in stage 2, we want to consider initiating more than one blood pressure medication to bring that down instead of starting with just one. And if we are doing more than one medication, the single pill combination options are preferred over multiple pills if possible. We have some enhanced lifestyle recommendations. The recommended weight loss goal is now specified at least 5% of body weight. So we want to see at least a 5% reduction in body weight if we're recommending weight loss. The goal for sodium intake is less than 2,300 milligrams a day, with the ideal level being less than 1,500 milligrams a day. This year, 2026, we have some updates in the dyslipidemia guideline, and actually they've retitled it dyslipidemia because they're expanding the scope to cover LDL, triglycerides, and everybody's new friend Lp(a). The previous guideline from 2018 focused on reduction of LDL by percentages. Now we're going back to absolute targets, and those are stratified by risk category. So basically, the higher your risk, the lower you want to push that LDL. I think I'm not going to read all these different categories. I think it will suffice to say that if you're not super high risk, but you do have some risk, you want that LDL to be below 100 for sure, and probably below 70. If you are high risk for whatever reason, you want that LDL below 55. I think that's probably good enough to move on. In the past, it was recommended to try ezetimibe before moving on to PCSK9 inhibitors. That is now no longer the case. You can choose either ezetimibe, a PCSK9, or bempedoic acid as your next choice after a statin. And then the inclisiran is a class 2A recommendation for people who either cannot tolerate or cannot obtain PCSK9 inhibitors. Lp(a), they're recommending universal Lp(a) screening at least once in a person's lifetime, and an Lp(a) level of greater than 50 milligrams per deciliter, which is 125 nanomoles per liter, is considered elevated. So for someone with atherosclerotic cardiovascular disease who has an elevated Lp(a) and their LDL is not at goal, you want to add a PCSK9 inhibitor, because those medications can be expected to lower the Lp(a) about 15 to 30%. For management of triglycerides, they have downgraded the strength of recommendation of icosapent ethyl over some concerns that a mineral oil placebo in one of the trials exaggerated the treatment effect of the medication. The brand name on that is Vascepa, so I'm more familiar with it. There's a new class 1 recommendation for olezarsen, which is brand name Tryngolza. This is an ApoC3 inhibitor, and that's recommended for people with familial chylomicronemia syndrome who have fasting triglycerides greater than 1,000 milligrams per deciliter. Again, the PREVENT tool is now the preferred risk calculator, and risk assessment now begins at age 30. Previously, that was age 40. And for patients who are age 30 to 59, it's recommended to get a 30-year risk estimate, which you get from that PREVENT calculator. There's a new dedicated guideline for cardiovascular kidney metabolic syndrome, also known as CKM. This is a syndrome that integrates obesity, type 2 diabetes, CKD, and cardiovascular disease into a unified system of predicting cardiovascular disease risk. So this is staged 0 to 4, with 0 being no risk factors, and stage 4 being either clinical atherosclerotic cardiovascular disease or heart failure in the setting of also having those risk factors. That's a new thing to me. I've definitely not incorporated that into my practice at all. And I don't think that's part of the PREVENT tool. I'm going to look at it just in case. No, the base PREVENT calculator from MD Calc that I use does not give you a CKM score. You get a 10-year total risk, a 30-year total risk, and then you also get risk scores separated into 10 and 30-year intervals for ASCVD, heart failure, coronary heart disease, and stroke. But I have not seen that CKM framework come up anywhere as far as I'm aware. There's some therapeutic recommendations using specific outcomes from the PREVENT equation. Those include SGLT2 inhibitors, now recommended for heart failure with mildly reduced and heart failure with preserved ejection fraction, as well as people who have both type 2 diabetes and CKD. Those SGLT2 inhibitors are recommended as first-line components of guideline-directed medical therapy. GLP-1s recommended for patients with obesity or other CKM risk factors. Non-steroidal MRAs, as far as I know, finerenone is the only one. Brand name is Kerendia, recommended for people with CKD and type 2 diabetes who have persistent albuminuria. And interdisciplinary care coordination is emphasized as a core principle. Well, that's helpful. You tell Dr. So-and-so I need to talk to him right now because AHA emphasizes interdisciplinary care coordination. I'm sure that'll fly. AFib, there's a new staging system for AFib. In the past, they classified it as paroxysmal, persistent, or permanent. Now we are using a 4-stage framework where stage 1 means at risk, stage 2 means pre-AFib, stage 3 means AFib, and stage 4 means permanent AFib. We've definitely seen this in practice that catheter ablation has been upgraded to a class 1 recommendation. So doing that as first-line therapy for AFib, especially in younger patients who have fewer comorbidities presenting with symptomatic paroxysmal atrial fib, and in patients who have AFib and HFrEF, since it seems to improve both left ventricular function and cardiovascular outcomes. Anticoagulation, decisions about whether or not to start people on anticoagulation are now based on annual thromboembolic event risk greater than or equal to 2%. DOACs are now preferred over warfarin, and aspirin is not recommended for stroke prevention. There are some trials that are challenging current recommendations for post-ablation anticoagulation, but those have not yet come into the formal guidelines. The option trial showed that left atrial appendage occlusion was non-inferior to oral anticoagulation for death, stroke, and systemic embolism post-ablation, and superior for non-procedure related bleeding, which makes a lot of sense. The Alone AF trial showed that stopping oral anticoagulation at least a year after ablation reduced composite events versus continuing the oral anticoagulation, and that was driven by reduction of major bleeding. Turns out people don't bleed if you don't put them on anticoagulation. How about that? And the Ocean trial showed that rivaroxaban did not significantly reduce stroke versus aspirin after successful ablation, although the rate of stroke in both groups of patients was very low, approximately 0.3 to 0.7 per 100 patient years. 2024, we have new information about hypertrophic cardiomyopathy. We have a class of medicine called myosin inhibitors, an example of which would be mavacamten. Those are now a class 1 option for symptomatic obstructive hypertrophic cardiomyopathy, which is shown to be refractory to beta blockers or calcium channel blockers. Those medications should be discontinued if the EF falls below 50%. We have a class 1 recommendation for non-invasive sudden cardiac death risk assessment in pediatric patients with hypertrophic cardiomyopathy. That's recommended at the initial evaluation and then every 1 to 2 years thereafter. And they have removed the age restriction, which was previously at least 16 years of age, for shared decision-making about ICD placement. So I guess if you're 15 now, you get some say in whether or not they throw an ICD in you. They have liberalized exercise recommendations for these folks, so participating in vigorous recreational activities has now been upgraded from Class 2B to Class 2A after annual comprehensive evaluation and shared decision-making. So there's no indication for universally restricting these people from vigorous activity. In patients younger than 45 years of age with non-obstructive hypertrophic cardiomyopathy due to a pathogenic sarcomere variant and who have a mild phenotype, valsartan may be beneficial to help slow adverse cardiac remodeling. For heart failure, the guideline from 2022 is still the most recent full guideline. They did make a couple of updates to it in 2024. These are expert consensus decision pathways. One for HFrEF, which reaffirms that our 4 pillars of guideline-directed medical therapy are the standard of care. Those would be ACE/ARB, ARNI being preferred, beta blockers, mineralocorticoid receptor antagonists, and SGLT2s. And it endorses rapid up titration of those medications with a goal of being at your target doses within 6 weeks of the patient being discharged from the hospital. Importantly, there is no optimal order of starting those medications. So for HFrEF, you get them on the 4 pillars in whatever order you can do it, and you get them up to the target doses of those medications quickly within 6 weeks. The other update for heart failure is for people who are hospitalized with heart failure. That emphasizes starting all 4 pillars of the guideline-directed medical therapy while they are hospitalized. Thank you for that from all your outpatient primary care colleagues. There are some additional notable documents. There are new sections in the appropriate use criteria for ICDs, CRT, and pacing. CRT stands for cardiac resynchronization therapy. There are new sections on pacing in the bundle of His and the left bundle branch, as well as leadless pacing. There are some revised recommendations for preoperative cardiac testing, preoperative beta blocker management, and risk stratification using a tool called the RCRI, which is the revised cardiac index for preoperative risk calculator. That's something I've heard of but not started using. Let me take a look at it. It's in MD Calc. The questions are, is this a high-risk surgery? Is there a history of ischemic heart disease? Is there a history of congestive heart failure? History of cerebrovascular disease? Are they being treated with insulin preoperatively? And is their preoperative creatinine level greater than 2 milligrams per deciliter? So it gives you a score and a risk of a major cardiac event. Interestingly, if you answered no to all of the questions, you still get a 0.5% risk of major cardiac event. No one's safe. I guess we should know that. And then if you answer yes to all of the questions, oh, that's interesting. The highest score is 6, and the highest risk of a major cardiac event is 10%. So as your number of yeses go up, your risk goes up to 1.1%, 5%, and 10%. So it looks like if you have more than 2 yes answers, you get a 10% risk. But then if you have all 6 answers, you still get a 10% risk. So I was thinking like maybe I should be using this instead of just Gestalt clinical judgment to figure out how to fill out these little forms that we get where they want to know if it's safe for these people to have surgery. I don't know that that's really a lot better than my clinical impression because it seems awfully non-specific and I don't know. I don't get a super useful vibe for that. I was about to click it onto the favorites for my ND Calc, but I don't think I'm going to after actually looking at it. And finally, we have some performance and quality measures regarding antiplatelet therapy, high-intensity statin use, RAS inhibitor therapy, and use of SGLT2s and GLP-1s. Okay, that completes the summary of guideline updates. I hope you found this useful. I learned a couple of things, so I hope you did too. If you have anything to add, if there's anything that I missed or said incorrectly, please let me know. If you haven't bought my book yet, Crooked Creek Serenade, please go buy that, rate it, review it. I'm trying real hard to push that. I've made a new Instagram just for promoting my writing. If you want to go follow me, it's Jody Marks Writes, JodyMarks WRITES. And I'm on there, man. I'm being obnoxious. I'm making videos and ads and posting all kinds of stuff, trying to get people to notice this book because I'm real proud of it. And I would like to sell a lot of copies of it. So if there's any way you can help me do that, please do it. And also, I hope you enjoy the book because it is a really good book in my biased opinion. And I'm working on the sequel. If you've already read it, thank you very much, first of all. Please go leave a review. And there should be a sequel at some point. I think that's all I have to say. Thank you so much for listening to Knowledgeable Provider. I hope that you have a great week, and I will talk to you later. All right, that does it for this episode of Knowledgeable Provider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, and subscriptions really do help the show, so please take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.